Central Jersey Family Health Consortium is pleased to present Addiction and Marijuana Use During Pregnancy and Breastfeeding. A couple of announcements before we begin. None of the planners or the speaker have anything to disclose. There is no commercial support for this webinar. And this program has been awarded 1 nursing contact hour from Central Jersey Family Health Consortium. To receive your contact hour certificate, you must register, listen to the entire webinar, and complete an online evaluation.
Our presenter today is Debbie Rasica. Debbie began her career as an occupational therapist before specializing in addiction. Graduating from Quinnipiac College, Debbie worked at Muhlenberg Hospital for 7 years, first as a senior therapist for psychiatric patients, as well as for patients detoxifying from drugs and alcohol. Work experience also included private practice specializing in depression, anxiety, and panic disorders. Additionally, Debbie served as the senior clinician in a long-term residential drug treatment program for 10 years. For the past 12 years and currently, Debbie serves as the coordinator for the Perinatal Addiction Prevention Project at Central Jersey Family Health Consortium. This program offers education, advocacy, outreach, prevention, and interventions to reduce maternal and fetal complications from substance use, along with the risks of substance use on developing brains. While at Central Jersey Family Health Consortium, Debbie has also become a women's treatment specialist, a certified tobacco treatment specialist, and a certified state educator, fetal alcohol spectrum disorders. Now, here's our presentation.
Good morning, everybody. Thank you for joining us for this webinar on addiction marijuana use during pregnancy and breastfeeding. I do not have anything to disclose for this presentation. The objectives we'll try to meet are to discuss addiction as a brain disease and to describe what marijuana is. Also, we'll be identifying maternal and fetal risks from marijuana exposure and discussing effects of marijuana use while breastfeeding. To begin, I'd like to talk a little bit about the disease of addiction, which we now prefer to call substance use disorder. It's a less stigmatizing term. But this slide just shows that the faces of addiction are many and that it truly has no discrimination. The next slide is pretty daunting, but it shows the changes that methamphetamines can have on a person's physical appearance and well-being. In these 4 pictures, not a long time has gone by since people started using. The top left one is only 8 months after that young girl began using. You can see the devastation on her face. Same is true for the other pictures. Let's talk a little bit now about what the diagnosis of a substance use disorder, better known as addiction for most of us, is about. In order to be diagnosed with this disease, 3 or more of the following need to be present over a 12-month period. This is according to the DSM-5. To begin with, a person must be building up tolerance to a substance. What this means is they need to take more of that same substance to achieve their desired effect. So if a person was able to feel relaxed and comfortable after 2 beers, after drinking for a while, they might need a 6-pack to achieve that same buzz that they've been looking for. With the buildup of tolerance, withdrawal also occurs. Withdrawal happens when the substance is leaving the body and a person becomes physically and psychologically uncomfortable as they're withdrawing from whatever chemical they're using. Another criteria for diagnosis is that folks end up taking larger amounts of their substance and over a longer period of time than they intended. So if a person chooses to think about going out for a beer after work, they're not stopping at a beer, and before they realize it, they've already had several. Another important criteria is that despite persistent desire and attempts to cut down or to stop or control use, this is not successful for folks who are dealing with this disease, despite their best efforts. In addition, a great deal of time is also spent in being able to obtain your substance, finding the space and time to use it, to recover from it, and then begin the process again. This can become completely consuming and does take over people's lives. So it will impact their social, occupational, recreational activities. All will be diminished because of all the effort and time it takes to use. I recall in my clinical days a client who was using so much cocaine that there was not any time left in his day for any other pursuits other than finding what he needed to be able to get high 7 to 8 times a day. One of the greatest um, criteria for diagnosing this disease is that despite knowing that there can be terrible physical and psychological consequences, a person is still not able to control their use. We often wonder why people who are ill, they have oxygen tanks, barely can breathe, are still smoking or drinking or using other substances. It's because they are unable to stop despite knowing what can happen. And as I said, 3 of these criteria need to be present over a 12-month period in order for a substance use disorder to be diagnosed. Substance use disorders are not a choice. Nobody chooses to be addicted to substances. This can happen to anyone, anytime, anywhere. And it really doesn't matter what your financial status is, what your education, your race, your creed, your cultural background is. This disease holds no discrimination. It's a chronic, progressive disease of the brain, and it is very similar to other chronic life diseases such as diabetes, cancer, high blood pressure, etc. Okay, now let's talk a little bit about the vulnerability for substance use disorder. What makes one person become ill and not another? That's a question people often ponder. If you have 2 teenage um, boys and they both have their first joint or beer at age, say, 16, who is going to become addicted? We need to look at those risk factors. The first greatest risk factor is early onset of use. New data shows that a person who first uses at age 15 is 7 times more likely to become addicted to that substance than if that person held off their first use until the age of 21. It used to be 5 times more likely to become ill, but recent data shows that it's 7 times more likely for a person to become ill the earlier that they start using substances. Once a person does start using, physical changes do occur in the brain, and depending on use, it may cause permanent loss of neurological function. Also, developmental growth can stop when use begins. So if the addiction launches and people continue to use, often that age in which they first used is the age of their developmental growth. So you might be working with an adult who might be functioning as a 15-year-old or a 12-year-old, depending on onset of use. The average first age of use is 11 to 12 years old. Other risk factors include family history. This is a big risk factor. If there's family history of addiction and or mental health problems, this can account to 40 to 60% greater vulnerability for a person to become ill with the disease of addiction. Active addiction or other traumas, such as domestic violence in home, also presents as another risk factor. Severe injury to a person or disease also can create a great risk. Another risk factor includes imbalanced brain chemistry. Often people will self-medicate to try to correct their brain chemistry, whether they're dealing with depression, anxiety, or other psychological problems. Peer pressure presents enormous risk, as well as environment, a person's personality characteristics, and another great risk factor is exposure to substances in utero. Young girls are particularly at high risk for substance use, and often they're using for reasons such as weight loss, stress relief. Often they're fulfilling multiple roles and have many stressors. They may be experiencing boredom. They may be searching for mood enhancement to reduce their sexual inhibitions. As I mentioned previously, to self-medicate for depression and/or anxiety, as well as to improve their self-esteem and their confidence. Additional risk factors for women include early puberty and if their mothers smoked or drank while pregnant with them. Young women binging, purging, excessive dieting, having obsessions with weight also present as additional risk factors. These risk factors can be pretty daunting, so let's look at a few protective factors that can help people not become ill with the disease of addiction. Parental monitoring and support is greatly impactful, as are positive relationships, delaying that onset of first use, being able to exhibit self control, having consequential thinking, healthy coping skills with resiliency, problem solving and decision making skills, education, anti drug use policies, as well as underage gambling policies, as often gambling goes hand in hand with substance use. Strong neighborhood attachments also prove to be a tremendous protective factor. Now let's take a look at the profile of pregnant women who are more susceptible than non-pregnant women for using substances. Those at a below poverty level income are typical of the profile, along with experienced trauma as a child, history of depression, anxiety, or other mental health issues, lack of education, managing life singly instead of with a partner, being unemployed, and involved in the criminal justice system, whether as a perpetrator or as a victim. Some behavioral characteristics that we might see with women using, as with most people, might be slurred speech, emotional lability, a mistrust of authority figures, inappropriate behavior, high agitation or restlessness, and a display of unhealthy coping mechanisms such as denial, blaming, rationalizing, and minimizing their issues. Symptoms of withdrawal might be seen as an increase in respiratory rate, yawning, wide mouth yawning, not yawning when we're just tired, but that wide mouth yawning that can be uncontrollable. We might see tremors and muscle spasms, anxiety, there might be nausea, vomiting, and eating disorders such as anorexia. We might also see piloerection, dilated pupils, tachycardia, diarrhea, eye tearing, or better known as lacrimation, and weakness and fatigue. Unfortunately for women, this disease of substance use disorders does progress more quickly than it does with men. Women, we tend to have a quicker onset of disease, and we end up with more substance-related diseases, meaning we become sicker quicker and with more physical problems and issues. We have a higher sensitivity to substances, and part of that is because our bodies have less water than men, but unfortunately more fatty tissue. As a result of this, we do tend to store substances in our system longer than men do. For us, one drink is pretty much equal to 2 drinks for men, so it's not a good thing for us to be drinking men under the table. We do have less metabolites in our liver to be able to metabolize alcohol and other substances, resulting in a higher blood alcohol level of the substances women use, and therefore creating more illness because of the toxicity of the substance. When substance use progresses to abuse and dependence, a multitude of problems can ensue, including our physical health, psychological functioning, interpersonal issues, impaired social relationships, difficulty with our occupational functioning, no matter what our roles may be, financial difficulties, spiritual bankruptcy, and that criminal involvement, again, whether as a perpetrator or as a victim. Most commonly, the top three substances abused by women include alcohol, marijuana, and opioids, which will include prescription painkillers as well as heroin. Now let's talk specifically about marijuana, as that's the greater focus of this presentation. Marijuana is made of plants. They're dried leaves and flowers and stems and seeds that come from a plant called Cannabis sativa or indica plant. The mind-altering chemical in marijuana is THC. That's the substance that gets people high, and that's what folks are looking for when they use. There is a mental as well as a physical addiction to marijuana. That used to not be the case. It used to be psychologically addictive, but not physically addictive. But unfortunately, marijuana is much stronger today in its concentration of THC, therefore creating that physical addiction. Therefore, a person will build up tolerance, meaning they need to smoke or vape more marijuana to achieve the desired effect they're looking for. And if they aren't able to use the substance, they will go through physical and psychological withdrawal. Marijuana is the most commonly used illegal drug in the USA. Approximately 22.2 million users have been documented each month. This is probably a much higher number. Presently, 1 in 10 users will become addicted to marijuana. And in ages before 18, 1 in 6 children or teens will become addicted as well. Most commonly, marijuana is smoked in joints or in a pipe, or in present day in vaporizers. There is increased use as the perception of safety is going up for the use of marijuana, and this does include our pregnant women, which is quite alarming. Marijuana does affect the developing brains in babies, children, and teens. The above are more susceptible to adverse effects as their brains are still developing. Marijuana can affect memory, both long-term and short-term. It can affect learning, attention, decision-making, coordination, regulation of emotions, and our reaction time, which can make it dangerous to drive while getting high. Long-term and frequent users do have increased risk of serious mental health issues such as psychosis, schizophrenia, depression, anxiety, and suicidal ideation. We are seeing more teens become ill with schizophrenia than we ever have in the past. Typically, schizophrenia does not materialize in young men specifically until their late 20s. Unfortunately, we're starting to see schizophrenia show up in our teens. We also are noting that suicidal ideation attempts and unfortunately completions have also gone up tremendously. And it is felt that marijuana is a large contributing factor to this. Some physical effects of marijuana might include respiratory problems, an increased heart rate, intense nausea, vomiting, and often folks can become dehydrated. Marijuana also is in foods and beverages, and unfortunately, this is even riskier than smoking because there's a higher risk for blood poisoning. When marijuana is ingested through foods and beverages, it can take almost 2 hours for a person to feel the effects of the marijuana. Since marijuana usually hits pretty quickly when it's smoked or when it's vaped, folks might take more than the recommended amount to try to achieve the high they're looking for. So if someone eats a brownie that is laced with the THC, that active ingredient that gets you high, they can have so much in their system that they end up with blood poisoning. We have to be careful of this because foods and beverages are not regulated at all. So folks can basically put any kind of labeling on packages that they would like. So people really don't know what they are ingesting. Marijuana also is manipulated into extracts and concentrates now. It's known as words such as hash, honeycomb, wax, keef, rosin, water hash, or just a few of the words. There are so many. I can never expect us to know all the terms, but know that the terminology is constantly growing as different types of extracts and concentrates are being manufactured. Using extracts is called dabbing. Unfortunately, once marijuana is manipulated into concentrations and extracts, the THC concentrate can be 40 to 90%. If smoking marijuana, which is the typical form of usage, pretty much folks will be receiving a 20% concentration of THC. So please take note of the market increase once marijuana is manipulated so that it can be put in what's called a vaporizer, which when used can be used without being detected because of the smell, which would dissipate very quickly when using a vaporizer. We also know that marijuana does impact fertility. Heavy male and female users do put themselves at higher risk for decreased fertility. Men may experience less seminal fluid and a lower sperm count. In addition, the sperm behave abnormally as the tails often can be absent or misformed, therefore creating poor swimming ability to be able to reach the egg for fertilization. Women may experience interference with their menstrual cycles as well as release of their eggs. And as we are born with all of the eggs we will ever have for reproduction, this is pretty unfortunate. Besides the eggs having difficulty releasing, they might also form a hardened shell around them so that penetration by the sperm for fertilization can be difficult. Even if people stop using years before they attempt to start a family, these problems can still remain. Now let's specifically look at pregnancy and marijuana use. As mentioned previously, there is a perceived safety in smoking marijuana today, and this is also true for pregnant women. As we're in our treatment settings, working with our pregnant women, often we will hear them say, well, at least I'm not smoking cigarettes, I'm only smoking marijuana. And they truly believe that this is a safer practice and they are doing healthy things for themselves as well as for their baby. Unfortunately, substance use disorders are greatly stigmatized, and even more so if a woman is pregnant. Pregnant women fear DCP&P becoming involved with them and their parenting if they reach out to treatment care providers for addiction or to their prenatal care providers. So often their issues with substance use do go unnoted. They will also often not access prenatal care. In addition, women as well as men are typically treated punitively rather than with support and passion when dealing with substance use disorders. The one thing we do know, as there hasn't been very much research on marijuana and pregnancy because it's a difficult thing to research, we definitely need to do more in this area, but it's very difficult to separate specifically what's coming from the marijuana and what are the other factors going on, including their environment, their nutritional intake. Are they smoking cigarettes? Are they using alcohol and other substances? How neglectful are they being of their self-care and of their prenatal care? maybe they're experiencing abuse, etc. The traumas can go on and all can influence the impact marijuana has on pregnancy. Secondhand smoke, which is the direct smoke coming off of smoking things such as a pipe, a cigarette, or a joint, can be damaging to the heart and blood vessels. Also can contain harmful and cancer-causing chemicals. This is the same as smoking cigarettes. So whether people are smoking marijuana or smoking cigarettes, that secondhand smoke is dangerous for a pregnant mom and for her unborn child. This is a time for pregnant women to be a champion for themselves and really insist that no smoking be allowed within the home, including other rooms where they think that might be safe. Now, how does marijuana specifically impact mom and her unborn child? Mom can experience a greater risk of miscarriage, early birth, which we know to be a leading cause of fetal demise. Mom can become forgetful, have lack of energy, slow reaction time, which might make her klutzier and more prone to accidents and injuries. It's toxic to her respiratory system and her immune system, may increase her heart rate. She may experience hypotension, decreased in oxygen flow because of all the carcinogens and other toxins in smoking. Her, her delivery may be prolonged or arrested because of her marijuana use. There also can be placental complications, which can lead to placental abruption, which we know can be fatal for mom. The baby might experience an increased risk of infection, shorter gestation, low birth weight, small head, and developed brain. Once delivered, the baby will later experience developmental disabilities, and newborns may show an increase in their startle response and have increase in tremors and have disturbed sleep patterns. There also might be an increased risk of cognitive and behavioral problems for that child as well. In addition, that child will be at a greater risk for addiction and mental health issues when they reach young adulthood. The risk of childhood cancer is also increased. Maternal use might result in the following types of cancer for the baby. These include non-lymphoblastic leukemia, rhabdomyosarcoma, which can be malignant, which is malignant typically, and it can be found anywhere on the body, astrocytoma, which is a brain tumor, and it also might increase features that are similar to fetal alcohol spectrum disorders, which surely indicates the toxicity of marijuana for developing brain cells. In addition, there might be susceptibility to asthma, chest infections, wheezing, and also ventricular septal defect. Believe it or not, paternal use can also have a great impact. If there is paternal use in the year prior to birth, that does increase the risk of rhabdomyosarcoma as well as the maternal use. Use during conception, during pregnancy, and postnatally also increases the risk for sudden infant death syndrome. This would be a result of second and third-hand smoke. Third-hand smoke I have not yet mentioned. Third-hand smoke are the toxins that linger on soft surfaces even after the visible smoke dissipates. So the smell that lingers is actually created from those toxins resting on soft surfaces. This is known as third-hand smoke. So is maternal and paternal use safe after the child has been born? Many people will return to use thinking it's now safe to do so. But as people use, they definitely can become more inattentive, certainly neglectful. They might sleep for longer periods of time and more deeply, and therefore not be aware of their baby's needs. This can create great safety risks for the baby and also risk that bonding experience if there isn't as much interaction as there needs to be. And if our babies have already been born unhealthy due to substance use exposure in utero, there's so much attention that they need, and marijuana use can definitely take away from that and create so many disparities for the baby. Let's take a look at medical marijuana use during pregnancy. Again, this is repetitive, but this creates such a risk factor. There is that perception of safety, that it's okay to use marijuana during pregnancy. Often it can be used to decrease chronic pain, to help nausea subside, and to help with difficulty sleeping. The recommendation is strong. As healthcare providers, we need to discourage use before conceiving, during, and after pregnancy. We need to help provide education on the potential risks for the baby and the mom as well. And we need to take mom's issues seriously and help her find alternative methods to help ease symptoms she might be experiencing. We want alternative methods that present less risk or instead present positive factors for pregnant moms, such as yoga, physical therapy, eating crackers for nausea, basically non-invasive practices that can help her relax, feel physically better, be able to eat, and to be able to sleep. The recommendations are strong, whether we're talking about the American Academy of Pediatrics, American Academy of Obstetrics and Gynecology, the National Institute of Health, Center for Disease Control, all advise no use prior and during pregnancy and after delivery. And again, so much more research is needed on this topic. Not only do we want to educate our health educators, but we also want to educate both partners on the dangers of marijuana use. Everyone needs to be in support of our pregnant moms. We recommend that all women are screened for substance use and that referrals for treatment and/or support groups are provided. In addition, we also strongly recommend that you contact the staff from the Perinatal Addiction Prevention Project at Central Jersey Family Health Consortium. We do have perinatal risk reduction specialists on hand to help with resources, treatment, and connecting whatever else our pregnant moms dealing with substance use might need. We also do not recommend marijuana use during breastfeeding. Trace amounts will show up in mom's breast milk. There are no known noticeable fetal effects at this time, but again, we have not done nearly enough research to determine any safety level and therefore should be avoided during breastfeeding as well as during pregnancy. We mentioned our parenting concerns. If a mom happens to be breastfeeding while lying in bed or lying on the couch, she can easily fall asleep. Baby might easily be suffocated during breastfeeding. And this is certainly something we want to avoid 100%. We do know that there is less milk production if moms are smoking while breastfeeding. Babies can become more sleepy, their sucking decreases, therefore they might have more weight gain and not thrive as they should. And even though it might be a trace amount, THC can last in the baby's system for 2 to 3 weeks after that exposure happened. And again, we are still concerned with later development of cognitive and behavioral problems for that child. So how do we reduce the risk? Mostly we need to avoid that second and third hand smoke. That can help enormously at this time. And again, these are strong recommendations that are supported by ACOG, AAP, NIDA, CDC, and LACMED as well. We strongly encourage no marijuana use during breastfeeding. In terms of alcohol, there are breast milk testing strips that will test if there is alcohol present in breast milk. These test strips are available in the commercial market. We would prefer women not used, but if women are choosing to have an occasional glass of wine, they do have the potential to test to see if there's any alcohol in their breast milk before feeding. There is no such test available for testing levels of THC in breast milk. So what do we do? Part of how we can keep our moms and our babies safe is to screen everybody for all legal and illegal drugs. Unfortunately, this is not the current practice. Women are selectively screened, but there is no universal screening in place. What else can we do? One of the most important things we can do is to ask open-ended questions about substance use during pregnancy. We can say to a mom, tell me about your alcohol and marijuana use before you knew you were pregnant. And how about in the 30 days prior to knowing you were pregnant? Tell me about your usage. That does not come across as threatening. And most women, if given the opportunity to speak honestly, they will. Another thing we can do is even just mention, hey, let's talk about your use in the present time and your partner's use. This is part of the 4Ps Plus, which is a screening tool used to assess for alcohol, tobacco, other drugs, and domestic violence that we encourage all prenatal care providers to offer their patients. It's critically important that we respond with empathy and without judgment. But it's often very uncomfortable for clinicians other than addiction specialists to address these issues. And part of those concerns is that folks often feel that they don't have enough knowledge or experience to address these issues, and often feel that they might be offensive to their patients if they address these questions. However, if these questions are routinely asked in practice, and we become comfortable with them, we can present them in a non-judgmental manner. We want to be approachable, and we need to ask all clients, because if we look back to that first slide of the picture of faces, remember this disease holds no discrimination. Often our patients on Medicaid or those uninsured will be drug screened, and many of the Medicaid HMOs do request screening in terms of reimbursement. However, those who are privately insured often are not asked these questions and screened for their substance use history. Please, again, reach out to us, the Perinatal Addiction Prevention Project staff, to assist you with education, literature, referrals for treatment and services. Our job is to make everybody else's job easier when it comes to substance use related issues. This is my contact information. Myself, as well as the rest of our talented staff, is available to assist you in any way that we can. Following will be some resources. This slide are some screening forms that can be used to become comfortable asking all patients questions about their alcohol, tobacco, and other drug use. The references are plentiful on these slides. This one, as well as a few following, carry a lot of information that might be helpful to further increase healthcare providers' knowledge about the risks of marijuana use during pregnancy and during breastfeeding. Thank you.
Thank you very much for that presentation, Debbie. I do have a question. In your slides, you noted that developmental growth stops when usage starts. Does that mean that somebody who starts using marijuana or other substances at 15 is sort of stuck at that age forever? Or would it their development continue if they stopped using?
Excellent question. Thank you, Lori. Development can progress and become unstuck if people engage in treatment and do the behavioral and cognitive work that they need to do along with the emotional growth. We often see folks stuck after heavy use and becoming pretty ill with this disease. But once a person engages in treatment and engages in the recovery process, growth can start to flourish again.
Hi, Debbie. I also have a question regarding THC and CBD. Can you tell us what the difference is?
Certainly, THC is the mood altering substance that's found in marijuana plants. The CBD is another chemical that's found in either hemp plant or a marijuana plant. And this is a non-mood altering substance. Right now, CBD is being looked at to reduce pain, help with pain management, to help with nausea, to help with sleeping, relaxation, with anxiety. And current research is being done, and it is indicating that this might be something effective that people can use, as it does not alter emotional responses from the brain at all. So THC is the active ingredient that gets you high, and CBD is another ingredient but does not cause those emotional changes in the brain.
So it would be true to say that CBD is safe to use. I'm seeing it sold all over the place. I'm just wondering, is it safe then?
That's a great question. Unfortunately, CBD is not FDA regulated. So therefore, folks can market CBD in any way they want. And we don't know what else might be in that. We don't know how it's been processed. So with no regulation, we can't say at all that taking this would be safe for a pregnant woman. Unfortunately, pregnant women, and we are also seeing that those in prenatal care may feel that CBD is a safe substance to use during pregnancy, but we have absolutely no research to substantiate that at all. We prefer our pregnant women to completely stay away from any substance containing THC or CBD at this time.
Thanks for that, Debbie. You mentioned that there are a number of perinatal risk specialists at Central Jersey Family Health Consortium. If I had a patient and I referred them to you, what kinds of referrals would you have for them?
We can help link them with any level of addiction treatment they may need, whether they need step meetings, support groups, outpatient, inpatient, medically assisted treatment, whatever type of addiction treatment they may need. We can also link them to providers who specialize specifically in dealing with pregnant women who are dealing with substance use disorders. We can also help connect them with whatever legal services they may need, social services. We have central intake available at Central Jersey Family Health Consortia, which is a wonderful program which can help streamline pregnant women having access to outreach programs that can help them navigate through their pregnancy and help access all the services they need, as well as any psychiatric and addiction treatment as well. We have such a plethora of services at our agency that we we have so much to help. So we hope that all prenatal care providers do reach out to us when they're faced with patients who are dealing with substance use disorders.
Debbie, you had mentioned edibles, and I'm just wondering, when you do go to purchase such something such as an edible, is the amount of THC listed on the packaging?
It might be, but it doesn't mean it's correct. People can put
Okay,
whatever they want on their labels.
Because nobody's monitoring it.
Correct.
I see. Okay, thank you.
Thank you.
Upon completion of the online evaluation, please contact Ann Ruck at amruk@cjfhc.org to request either your nursing contact hour certificate or your certificate of attendance. You can also reach out to me to request a copy of the PowerPoint presentation. Thank you.